So 25 small squares in each large square, 25 small squares in each large square. You have a large square of totally together, there are 25, either looking to the amplitude and the time. The large square is 0.2 seconds, as I mentioned here. So whenever you are reading the ECG or interpreting ECG, there are 5 steps. Just easy to remember. The 5 steps are: look at the rate, look at the rhythm, look at the P wave, look at the PR interval, and the QRS complex. These are the things whenever you see ECG immediately after looking at the speed, what has been said for. Otherwise, you'll have a miscalculations. Then interpreting ECG, how to take care of heart rate. There are different people use different methods. Most of things has been discussed here. Again, count the number of electrical impulses as represented by PQRST complexes conducted through the myocardium in 60 seconds. That's 1 minute. So that is heart rate per minute, which is normally 60 to 100. And the atrial rate, count the numbers of V waves, which is representative of atrial kick, and ventricular rate, count the number of QRS. But again, when you look at the heart rate, whether the different method I told you, if the 6 seconds method is, denote 6 seconds interval of EKG strip, because as I told you, 0.2 seconds is one big square or 0.4 is small. When you look at that, 6 seconds means how many 6 seconds? That means 0.2 divided by 6 seconds. How many QRS complexes come into that? That is going to be the heart rate. For example, count the number of QRS complexes occurring within the 6 seconds. So if you see 5 big one is going to be 1 second. That's 0.2 seconds to 1 second. That means 6 seconds means 5 into 6, almost 30. In the 30 boxes, how many are there? Then multiply the number by the 10. So that becomes the heart rate. That's one way of calculation. Another way is that look at the strip of this one. If you have large square method, this is called large square method. So when you have a large square, this is large square. So you have large square is equal only one. That means you have only one large square between the two PQRS complexes. That means it is going to be 300 per minute rate is the heart rate. Or if you have a 2 large squares between the 2 PQRS, that means it is 150 beats per minute, because 300 divided by 2. And we have 3 large squares. So that means it's going to be 100 beats per minute, because 300 by 3. So that is how it's another way of calculating. The rate of the heart rate can be between the RR intervals in the large square. How many are there? You should divide with the numerics of the number of these large squares under 300. Okay. When you do this, please remember here, the speed should be 25 mm per second. If this speed is going to change, this is going to change, because the duration is going to be 0.2 seconds only when you keep the speed of 25 mm per second. Okay, that is how we should think about it. So you have to see this before you calculating any of the times of the rates. And if the squares of the large squares are 5, it is going to be 60 beats per minute. So that's how we can calculate the rate in another way. So again, another method is that you have a smaller things. For example, as we told, the each is going to be 0.2 and this one is going to be 0.04. So if you have how many squares of smaller things? So that means the same thing. The above, if you look at it, this is you are calculating with the bigger number of this one or 2, and you are calculating the smaller space. So that time it becomes, because 300 when you have a 1 and 1500 because it's a 5, no? So automatically it becomes 1500 by the small squares. So again, if it is going to be big, 1500 by small squares, which is going to be 10. So that is how we can calculate. If it is a 1500, becomes when in the top model and the denominator, and it's going to be the smaller is going to be the same numbers of this rhythm. So now we got the rate. Now we look at the rhythm. What is the rhythm? Whether it's a properly regular, we understand the rhythmic situation. When you have a music, it's very rhythmic. So that means beat to beat properly is there. So here, a sequential beating of the heart as a result of the generation of electrical impulse. That means as it's having a impulses of that electrical impulses, and the beating is sequential and continuous. So without any disturbance. So that's called at that time when it's rhythmic, again, it is a regular or irregular. How do you say regular or irregular? When the interval between the R waves is regular, that means when you have a upward declination of PQR, R wave interval is regular. So that means it is regular. And interval between the R waves, that means, for example, there is irregular here, you can see it just for a calculation. But if it becomes same regular, that is regular. Now this is irregular because 1, 2, 3 is there. That's how we can say a regular or irregular pattern. That's a second after seeing the rate. So in this year, measuring a regular rhythm, measure the interval between the R waves. Normally from R to R, that means from here to here. You look at it here, 1, 2, 3, and almost 1, 2, 3, 4. You look at here, 1, 2, 3, and again this one. So it is whether it's a regular depends on this. Please understand, as we told you, what is the interval between the varies, because most of the times it can be 0.06 seconds to normally it is up to 0.12. So the interval vary less than, if it is less than 0.6 seconds, it is again abnormal. And it should be by, if the interval vary by less than 0.2 seconds or 1.5 small squares, this is small square. If it's less than 1.5, we'll show in the coming slides and coming classes. So the rhythm is considered to be regular. That's what you need to understand. So interpreting the easy rhythm step by again rhythm, measuring in the irregular rhythm. So look at it. The rhythm here is the RR interval from R to R. As I told you previously, 1, 2, 3, 4, and here only 1, 2, 3. That means it's not regular. So if the interval between the R wave are variable by greater than 0.06 seconds or 1.5 small boxes, the rhythm is considered to be irregular. So if it is going to be abnormal between the two RRs, that's called rhythm. So first rate is completed. Now we complete the rhythm. So rate and rhythm is being checked now. Here, again, look at when you are looking at the rhythm, the P wave is produced when the left and right atria is depolarized, because both simultaneously having a depolarization, that means contraction. So when both atrium is contraction, you are going to get the P wave, because atrial contraction, atrial peak is a P wave. So here we will come back to that again, it comes in the next slides. So what happens? The first deviation from the isoelectrical line is a P wave. This is a P wave which should be upward, rounded, which should not cross more than one small box and should be rounded. And P wave is the SCR node basing or firing at regular intervals. So here this pattern is referred as sinus rhythm. Whenever we have a P wave preceded by QRS or P wave, the QRS preceded by P wave regularly. So P wave is produced and it is the P wave regular. So that's called, this pattern is referred as sinus rhythm. So please understand, we talked about rate, now we talked about rhythm. In the rhythm, we looked into three things. One, the difference QRS and QRS R interval, and the P wave is preceded. So that's what that is there. It's a regular rhythm. Only in a P wave, what happens? Normally, as I told you, both atrial contraction is a P wave. In a both atrial contraction simultaneously suddenly contracted at one time, one go. That means P wave looks like this. Okay, so P wave looks this upward and rounded more than this. And right atrial enlargement, what happens? Both right and left atrium is there. Right atrium is little bigger than the enlargement is there. That means when right atrium is contracted, there's a bigger P wave together. This is what both together. When the first right atrium is there, that becomes actually, we have a patient first wave is up and coming, which is going to be this one. At the same time, if we have a left atrium, automatically it is a widened, looks like here, that's called P mitral. So whenever you have this one P mitral, it is a left atrial enlargement. Both together, if you have a right atrial enlargement and P pulmonale, this is called P pulmonale, this is called P mitral. So pulmonale means the first right atrium have more enlargement and contracted, whereas left atrium is contracted, it has a P mitral. And when you have both together, you have this right atrial enlargement plus left atrial conduction is having bigger than the normal size because both are being enlarged, take long time to have a deflection upwards. So, do all P waves look similar? Depends on, as I told you, this is how it is. Normally, the chest lead, when you have a limb leads, the difference, because as I told you, the deflection in the chest leads, it's less than 1.5. In the limb leads, it's at 2.5. So, normally, it is less than 3 at any given point of time for P wave. Smaller space at a standard settings. So, are P waves present or not? Has to be seen. Are P waves occurring regularly is more important, like a PP interval. And is there a P wave present for every QRX present? That please understand. P is present for every QRX complex is very, very important. Then are the P waves smooth, rounded, upright in appearance, or they inverted? As I told you, this is what difference of P wave, how you can see and represent ECG, and you can identify differential diagnosis of this. This is how the P wave. Now, coming to the PR interval. What is PR interval? So PR interval is nothing but it measures the time interval from the onset of atrial contractions to the onset of ventricular contraction. So look at it here. Please just forget this white strip because the black line is just to understand how different it is for a splitting of color change and everything, because otherwise calculations becomes difficult here. If you look at it 1, 2, 3, 4, 5, 6, it becomes, because if you calculate here, it should be 3 to 5 small squares in the color coding. And the measured from the onset of P wave to the onset of QRS complex. At the onset, because onset starting of the P wave, where the atrial kick, atrial contraction is there, till the ventricular contraction is called PR interval, which the normal interval, please understand, it has a lot of implications. The drug toxicity, it has implications in the problems and whether we want to give pacing, whether you want to give all these things makes a difference. So need to understand that interval should be between 0.12 to 0.2 seconds only. So the measurement of the P wave onset of the QRS complex is called PR interval. That's what significance we talk. So whenever you have ECG rhythm strip of interval, PR interval, how to do this is how you can look at the both red lines here, starting of the P wave and just before the Q. Okay, before, just because Q has been dipped already. But whereas this one, if you go straight here, is come. So that means PR interval is PR. They're not talking about Q here. PR, because Q is a deflection down, the first deflection. So PR interval point, the indicates where calipers would be placed measured. That's called here, we call it as, it is onset of atrial contraction to the onset of ventricular contraction. Because in the onset of ventricular contraction, first deflection comes. That's the reason that's called PR interval. Now, you have to ask for 3 questions when we talk about a PR interval. What are the 3 things you have to talk about? Are the PR interval greater than 0.2 seconds? As we told here, please remember, it is 0.12 to 0.2 seconds. Is it more than that or not? Is the first question. The second question is that are the PR interval less than 0.0 to 0.12? That's again, look at it. That's we need to understand. So it should not be more than 0.2. It should not be less than 0.12. So then the important thing is, are the PR interval consistent across the ECG strip? Like for example, the differences are, we'll come to know, because it's every one of us have been, almost everybody has been married. We know it has been implicated with a life and relationship between the husband and wife as the days and the years goes on. And that's the easy way to remember it comes. There, the interval between this, how the ECG strip has been continuously consistent or not to be checked. So these are 3 questions to be answered when you look at the PR interval. Now, coming to the QRS complex. In the ECG, the QRS complex. The QRS complex presents depolarization or contraction of the ventricle. So what is a QRS? That's the first negative or downward deflection of this large QRS complex. And again, remember that all together, it has to be 0.06 seconds to 0.12 second only, which is 1.5 to 3 small boxes only. So R wave, the first upward or positive deflection following the P wave, because after the P wave, Q almost always downwards, and the first upward deflection is nothing but a R wave. So the which is the normally tallest waveform in the ECG, except sometimes with a very high potassium is there, which becomes equal to the T wave. So S wave, the sharp negative or downward deflection that follows R wave is a S wave. So now we will talk about that later again. What are things here in a QRX complex? Again, you look at it, this is the two red lines indicates where the QRS is being measured. The duration should be 0.06 to 0.12. So that has been clearly mentioned here. Please note that point. So now, again, as we talked about the P wave, three things to be asked for. Here again, QRX complex, three things to be asked for. Number one, whether it is greater than 0.12 or it is less than 0.06. Are the QRS complex similar in appearance across the ECG strip? The same way like PR interval, here you please understand, is it a similar appearance across the ECG strip? Is the one when you are looking for QRS complex. When you are looking at the ECG interpretation practicing, please remember here, as we already know that looking at the box size, whether you have 1500, whether 300, whether you are taking care of 6 seconds and calculating with the multiply by the 10. Finally, it is the same. The boxes between the R's, again, if there are 19 small boxes are there, that is 79 beats per minute. And regular or irregular, that means the between the R and R almost every time same. So it's a regular. So RR are equal in every continuously. And the P wave for every QRS, whether there is a P wave for every QRS is there or not there. So it is there. So that means there is a yes. Then PR interval, PR interval, PR interval, PR interval. Look at it. So from the beginning of the P to the QRS, whether it's 0.16 or not, and should not cross 0.2 as we told you. And measuring of the QR, as we told you, 0.06 to 0.12, which is here you can see that, which is, as we told you, each small box is going to be 0.4 or the big box is 1.2. So that means 0.08. That means almost smallest things are almost two boxes. So that means this is how to normally you interpret ECG when you read it. So coming to the interpreting ECG rhythm in the T wave. So this is what is a T wave. It's called ventricular repolarization. So this is also called repolarization, nothing but relaxation. In the relaxation or contraction, if you look at the 0.
Stop.
Sir, you are not audible, sir.
Not moving also.
Yeah, yes, sir.
I think he has a connection problem. Let him sort out. The delegates write in the chat box, what is that scheme of evaluating an ECG? Order. Please start writing in the chat box. What was the scheme he described? One, Maharaj, you need to share your presentation again. You are mute. You need to.
Do I need to share it again?
No, it was stopped.
Your presentation stopped, Mohan Maharaj. So you need to share your screen.
Share it again and advance it and talk.
Is it okay?
Yes.
No,
So shall we wait for
Yes,
your
yes,
questions and complete?
No, they have not started answering. So you
Okay.
can.
Shall I continue?
Yes,
Yeah.
sir. Yes, sir. It's visible.
Please.
Be awake. All the students be awake.
Okay. Shall I continue, Diwan sir?
Please go ahead. Don't stop.
Please continue.
Okay. So interpreting ECG rhythm strips artifact. So when there is an abnormal or problems are there, how to see. Whenever you look for any this one, you will have artifacts for these reasons. One, patient is moving, which is the most common. Second, the electrodes which you place here, it has a loose or defective, not working. Or if it is a improper grounding, that means earthing is important. because it's there or not. So grounding is not there, and interface is not there, and faulty ECG apparatus. Anyway, that's how it is going to be. So whenever there is a all these reasons, you will have a artifacts. That means the ECG you cannot read. So you're taking the ECG also should be taken care while printing the ECG properly. What is a sinus rhythms? So what do you mean by sinus rhythm? So rhythms that originate in the sinoatrial node, which has a 5 common variations are there in that. Normally you can call it as, that means sinus is normal because it's coming from SA node, it's going and having a contracting and ventricular contraction is there, everything is there. But here again, you have a different without any problems. So maybe if you have a problem, we need to treat. That means either abnormality in the blood pressure, abnormality in the constant, but otherwise, there are 5 common variations. One is a normal sinus rhythm, which the rate is 60 to 100. And sinus bradycardia, if the rate is less than 60 beating per minute, beats per minute, or tachycardia whenever it is more than 100 pulse per minute, beats per minute, or sinus arrhythmia, that means there is a arrhythmia. Rhythm means regular, and arrhythmia means the absence of rhythm. So that means rhythm is being gone, but still sinus. So that time, that's again, it can be 60 to 100 beats per minute. So again, it is a sinus pass arrest. So any of these variations can be seen in a sinus rhythms. So we look at that again. What is a sinus, normal sinus rhythm? The sinus rhythm is normal, regular rhythm of the heart set by the natural pacemaker of the heart called sinoatrial node. It is located in the wall of the right atrium, which we already mentioned. Normal cardiac impulses start there and are transmitted to the atria and down to the ventricles through the mechanism what we mentioned and actually depicted in the diagrams and clearly explained to you in the previous slides. So what happens here? There is a regularity. And remember, this is one thing easy. If you understand this pattern, easy to do for every step, for everything, every rhythm. Because as we told you, rate, rhythm, P wave, PR interval, and QRS complex. All these 5, how we are going to see. What is the rate? We all know 60 to 100 beats per minute is normal sinus rhythm. And rhythm, as we told you, how to look at the rhythm? Atrial rhythm is regular, both because PP and RR. So atrial rhythm is regular, ventricular rhythm is regular. Both are regular. That's what is the rhythm we are looking at. Then the P wave, we understood the P wave, different P waves also. There at the same time, is the P wave before each QRS? So yes. And are P wave upright and uniform? Yes. So this is what a P wave. Then what is the length of PR interval? So it should be between 0.12 to 0.2 seconds. So then only the PR interval is a normal and correct. So regular again, please understand. So this is what you look at PR interval. So then do all QRS look alike? Except maybe some small, hypotension, having some other normal breathing pattern of inspiration, expiration, we'll come to that. So what is the length of QRS complexes? So it should be the 0.06 to 0.12 seconds. And whether the complexes all look like same? Yes. So this is what the 5 steps to identify normal sinus rhythm. That's how we read ECG. Then what is sinus bradycardia? That means the rate is less. Though when the heart rate or beats per minute less than 60, and it is sinus bradycardia, and normally it varies, simply like, when have it can be having sometimes normal variations in athletes, because when police people are real hardworking farmers, they have a rate less. At the same time, during somebody like sleep apnea or deviant sleep, those kind of people, and in response to vagal maneuver is nothing but whether you have a massage for SVD or you just blow like that, or you have a modification like, put the patient 15 seconds, slide light load and put the legs raised and see after 1 minute. These are different modified Vaxello maneuver. When you put that vagal maneuver, when you're doing that, how you're going to, that can be changed. Now, the sinus, identify the sinus bradycardia. Again, look at all these 5 things are same, no difference. So it is less than 60. And here, regular, yes, normal, and these are all normal. No difference here except this. That's why it's called sinus bradycardia rhythm. So except the rate, Nothing, no difference between the previous what we looked into the pattern. Easy way to remember. That's a bradycardia. Now, tachycardia. Again, look at it. Same thing. The rate is being increased. What are the things here again? Please look at it. Normally, up to 150 you can consider. As per our CCLS is 101 to 160 beats per minute. And again here, the regular. Yes, yes. 0.1 to 0.2 seconds. No difference. And again, look alike. Yes, same. Length, same. So there's no difference there except it is sinus tachy or brady. Only the rate is different. Now, in sinus arrhythmias, what is it? Sinus arrhythmia is a normal variation in the beating of your heart. There is a variation. So it refers to irregular or disorganized heart rhythm. Irregular or disorganized heart rhythm. So this rate usually increases with inspiration and decrease with expiration. It is again, if it is more than 10% of the difference is there, you should be more worried. So again here, the rate is not changed. Look at here, the rhythm is irregular. Again, varies more than 0.08, which should not be, as we discussed previously. But at the same time, both are as P wave, every QRS before is there, and again upward, no problem. There's no problem here. There's no problem in QRS. Everything is same. Only thing here is comes the irregularity of this rhythm is there. Where you look at it here, the atrial rhythm and ventricular rhythm, there is irregularity. That's called sinus arrhythmia. Now, look at basics to interpret arrhythmia. It's nothing. Rate and regularity of the rhythm, appearance of P wave, relationship of P waves to QRS complex, and normal sinus rhythm is 60 to 100. So these are not there, and that's how we approach and we see what is arrhythmia. And how do you interpret? Normal sinus rhythm is not exactly regular as it varies with breathing. And when the PP interval varies more than 10% with breathing, then it is a respiratory sinus arrhythmia existing. So let us talk about the reasons later. So variations, otherwise results of sinus node dysfunction, aging, and digitalis toxicity, intoxication is the normal causes. And absence of a recurring pattern of QRS, that's irregular with a non-apparent P wave suggest atrial fibrillation, even with QRS aberration. So, how do you interpret? Tools to interpret. Complex tachyarrhythmias often require more than two simultaneous leads for diagnosis. That means whenever the complex, you have to look at the two leads. You look at the two simultaneous leads. We have to represent and see the diagnosis to make it. So, to assess the relation between the atrial and ventricular depolarization, that's depolarization. See at least one lead that maximizes P wave. So, P wave maximization mainly seen in lead 2, lead 3 AVF or V1. Okay. And 12 lead ECG may be needed for diagnosis to document response to the management as well. So atrial rhythms these are the normal rhythms. The most of the common thing is atrial fibrillation. Then the next common is atrial flutter. Then comes supraventricular tachycardia, premature atrial, that's called PA6. So these are the four most common atrial arrhythmias which actually causes, these are called atrial arrhythmias. Flutter is nothing but there's something called F wave. That means it's not a P wave, which looks like a sawtooth appearance of irregular. Regular, it's not irregular, please remember. When you look at it, it's a regular. F waves becomes almost like a regular. It may not have a clear-cut measurement of which mechanism it goes. So atrial flutter is coordinated. It's a coordinated, rapid beating of the atria. Okay? It's the second most common tachyarrhythmia. And this is how it is normally 250 to 400 per minute. And ventricular, it can vary. Depends on how much is going to take activity, how much the VA node, when a ventricular node has been taken, how much has been firing. That depends on the rate is going to differ from ventricular. And please understand, atrial is regular and ventricular may be irregular. Depends on most of them because the VF and VTV continues to not be there. And if there is a P wave before each QRS, normal P waves are absent, which F wave would also call flutter waves. So it looks like a sawtooth. What is the length of PR interval? Not measurable. Okay. So all QRS complexes look like yes. Again, the size is not going to change of the QRS. This is atrial arrhythmias. So whether you call it supraventricular or atrial arrhythmias or these are the four things. You call it as supraventricular because not below the ventricle. So atrial fibrillation. This is irregular. Again, look at it, which is the most common arrhythmia. 85% of the people who experience is older than 65 years, and it has 400 times per minute. That has 250 to 400 is 400 times per minute. Ventricles do not receive regular impulses. So this is again, there is no distinguishable P wave at any point of time given, and it's not like a similarity. So this is atrial fibrillation. Again, look at it here. The rate is per minute is 350 to 400. Ventricular variable, as we said, irregularly irregular. And the normal P waves are absent, which is replaced by F waves in other sometimes of this one. And length of air will not discernible. Please understand the difference between here. Length of, see, look at it. The QRS complexes are look alike, whereas Q complexes are look alike. Yes, the issue is going to be the no difference here. But whereas the length of air interval is not measurable, and length of interval is not discernible. So difference of these two things are fibrillation is different. And supraventricular tachycardia. I think most of us, as anesthesiologists, we know in the operation theatre we see. But only thing is, we think when there is 150 beats per minute, normally 100, we call it a tachycardia. But supraventricular tachycardia means the QRS is not affected. So again here, look at it. Atrial, regular, ventricular, regular. No difference here. But at the same time, the rhythm is regular. The P wave before QRS usually not discernible, especially at the high rate. So becomes hidden in the QRS. So what is the length of PR interval? Usually not discernible. And if you see the QRS complex locally, yes, again, there's no difference. So the difference between the PR interval is going to be a problem here. So now we finished atrial. Let us come to ventricular rhythms. When sinoatrial, we'll talk about this. When the SA node and AV junction tissues fails to generate an impulse, that ventricle will assume the role of pacing the heart. As we told you, we showed three pacemakers: atrial pacemaker, ventricular pacemaker, and the wall of the ventricle. The three levels of the rates have been said. So here, with this, when there is an absence of P wave because of there is no atrial activity or depolarization. So ventricular rhythms will display QRS complexes that are wide, greater than 0.12 and bizarre in appearance. So what is going to be the most common variations? The most common variations include the premature ventricular contractions, PVCs. 8 rhythms are lethal ones. Know this, please red mark, remember this here. Idioventricular rhythm, the ventricular escape rhythm, rate usually 20 to 40 beats per minute. Accelerated idioventricular rhythm, more than 40 beats per minute. Agonal rhythm, more than 20. And ventricular tachycardia, more than 150. Ventricular fibrillation, torsade is D points, pulseless electrical activity, and asystole. These are all 8 rhythms which are lethal ones. We should all know, all should know this, because then we know what to do or whether to give shockable, non-shockable, we'll discuss. So premature ventricular contractions. What is premature ventricular? A PVC is not a rhythm, but an ectopic beat that arises from an irritable site in the ventricles. So what is the irritable site? As we told you, the SA node has consisting of automaticity of the rhythm, which goes in now, it's actually, there is irritable site in the ventricle. Normally when there is a MI or the star happens, there is irritable site which can cause PVCs. So PVCs appear in many different patterns and shapes, but are always wide and bizarre compared to the normal beat. So this is called PVCs. How to really look at it? Easy. Again, the same way, 5 steps to identify everything, every rhythm, every pattern. Look at it, how it goes. What is the rate? Atrial, usually normal. Look at it. Atrial, usually normal. What happens here? Ventricular, usually normal, depends on the underlying rhythm. What is the rhythm? What is the rhythm? Rhythm, you have to see PP and RR. What happens? Depends on, again, underlying rhythm, irregular PVCs. There is no there is an irregularity between these PVCs. Can you see this and this? So, is there a P wave before each QRS? No. there is a QRS here, there is a QRS here, and look at here. But again, here it's there. And look at this. So absence with, is there a P wave before each QRS? Absent with PVCs, because there's no P wave is being seen here, because you can see here P wave, there's no P wave here. You can see here, there's no P wave here. Only T wave is there, after no P wave. So that means in the PVC, there's no P wave. Are P waves operating when there is no PVC? Is what to talk about PVC? Now, the length of PR interval, again, you cannot measure because continuous is not there. Please understand again, QRS complex look alike, QRS complex are not looking alike. And what is the length of QRS? Again, complexes, you see, its wide varies and occurs earlier than the expected, because that is the reason you are not able to see the P wave here, because between 1, 2, 3 here only 1 and 2. And look at 1, 2, 1 and 2.5, 1, 2, 2.5, but again only 1.5, 2. So that means it is actually earlier than the expected. So what are the types of preventricular ventricular contractions pattern? Again, depends on if it is ventricular bigeminy, it comes every alternative, because this is how it comes. And couplets, that means coming 2 times, 1 by 1 afterwards immediately. So actually we call it as ventricular bigeminy, ventricular quadrigeminy, and runs ventricular tachycardia. Depends on beat, if it's going to be more and again. So which occurs every other beat is called bigeminy, and trigeminy, third beat, fourth beat, and together coming together, and this is how we can call it as a ventricular tachycardia coming continuously, like not 1, 2, 3 more and more coming. It comes to the other ECGs again. Idioventricular. What is idioventricular? Without any cause, suddenly it's coming. That will come to know the cause again. So videoventricular arrhythmia is also termed as ventricular escape rhythm. So it is a last ditch effort of the ventricles to try to prevent the cardiac standstill. That means we call it as in the respiration agonal breaths. So agonal breaths to be considered as arrest. So like that, at the end of the stopping, before the stopping the ventricle, there is a, before going to the standstill, that means heart is not working, there is a last ditch effort of ventricle is called idioventricular rhythm. So the SA node and AV node have failed totally. Both are failed. Now rate usually between the 20 to 40 only. So, and always, most of the less minimum cardiac output is required is 2.5 liters per minute, and which is reduced here to the maximum compromise. So output is not there. So what are the keys to identify this? Rhythm is very slow, no P wave, wide and Bijare QRS. So again, no change here, look at it. Rate is 20 to 40, usually regular, P wave is absent, length of PRR is not measurable, and QRS wide and Bijare. So, sir, dear Divan sir, already 50 slides. Hope we have another 20 minutes time to talk. Is the time is okay, sir?
Please go ahead.
Yeah.
This, as I said earlier, this is the longest lecture.
I understand, but we have completed only 56 slides out of 100. I just wanted to remind it again. Because the concentration should not be more than 20, so we need to recap them, because I thought you will put 1 or 2 words in between so that people will come alive and come back to. So accelerated idioventricular rhythm. So accelerated idioventricular rhythm is the last ditch effort of the ventricular to try to prevent the cardiac state, as I told you. So again, the rate usually between 40 to 100 depends, and cardiac output is compromised. So this is again same way. The only thing is this is changed. The rate is being changed. Everything else is like a routine of, you look at same way of looking at idioventricular rhythm. And this is accelerated. That means the rate is more, nothing more than that. So agonal rhythm. So please, it's more further worsening. It's when the idioventricular rhythm is 20 beats or less per minute. So that's how these 3 things again, it's almost agonal idioventricular and accelerated idioventricular, which is totally compromised. So again, same thing, very slow, and same thing of other things. Now come to ventricular tachycardia, which are very important for all of us. We were yesterday discussing about sudden cardiac arrest, which 70% of the people will get into VFVT, and that's where the importance of early defibrillation, early AED or early cardioversion are important. Other than this SVT things, I started with discussion of more about 120 joules in the other countries where the ones are witnessed recently. And this ventricular cardia identification becomes very, very easy. Very easiest thing to identify, which is almost always occur in diseased hearts. Rhythm in which 3 or more PVCs arise in the sequence. 3 or more, please remember, it doesn't have to be fully. And the rate greater than more than 100 per minute. And the ventricular tachycardia, we call it as a VTAC, can occur in short bursts lasting less than 30 seconds. That means less than half minute, causing few or no symptoms. So again, that will depends on why QRS listeners will come to know. The sustained ventricular tachycardia lasts more than 30 seconds and requires immediate treatment to prevent death. So this is an identification which is required by every doctor, and that saves a lot of lives. And where our real goal of CCLS. So VTAC can quickly deteriorate into ventricular fibrillation. So now we will discuss what are this, how it is. The rate of ventricular tachycardia 101 to 250. So it is just tachycardia more than 100, and ventricular tachycardia it will be between 100 to 250. And the rhythm, atrial rhythm is not distinguishable, and ventricular rhythm is usually regular. Look at it. It's very regular. Very regular, but atrial not distinguishable. And the P wave before each QRS, no. Regular PR interval not measurable because depends. There is no P wave where to measure. And the QRS complex looks wide and bizarre. But again, look at it, more than 0.12 seconds. More than 0.12 seconds. So VF, what is the difference between the VT and VF? Look at it. Which ventricular fibrillation is nothing but it's a coarse and fine, occurs as a result of multiple weak ectopic foci in the ventricles, no coordinated atrial or ventricular contractions, electrical impulses initiated by multiple ventricular sites. That means there is everywhere electrical impulses initiated and are not transmitted to the normal conduction pathway. It is a bizarre in a different way. It's not going the same way. So that is why look at the how the VF looks like. It is a coarse VF. It is a VF. The difference of these two is how normally we can think about PEA sometimes, systole sometimes also looks like confused by this. So identification is what is the rate? No. Rhythm rapid, unorganized, not discernible. P wave before QRS each, no. And P wave upright, nothing, we can't see. What is the length of PR interval? None. Because there is no P and where to count about PR interval. And do all QRS complexes look alike? What is the length of QRS? None. Whereas here, it is a difference is there is a look-alike wide and bizarre everywhere having more than this, and here is the none. So that is a difference between the look at the VF and the VT. These are important to remember. Asystole. We all know that's the reason, as yesterday they were telling about, even the patient is respiration, you are putting the pulse, you are not feeling means you are not able to feel it. Otherwise, patient will not have a breathing. That's what he told, sir told easily. So ventricular standstill, that means there is no contraction, there is a straight line. So ventricular is nothing but asystole. That means there is no contractility. Again, look at it, simple. Rate, rhythm, QR, everything is none. So, what is pulseless electrical activity? We all know electrical activity is being coming from the heart as the contractility or a waveform or as we discussed, but there is no pulse. So that means EC is being seen clearly, but the pulse, that means that effort is not reflected to the flow of the blood or pulsatility is not there. So, but the mechanism of the pumping are not happening. The absence of palpable pulse and absence of myocardial muscle activity with the presence of organized electrical activity. So on the cardiac monitor, but not looking at the pulse. The patient is clinically dead despite some type of organized rhythm on monitor. Please remember this. That's the reason when you say that pulse is not there means no, just go ahead with the CCLS. Now, we'll come to the heart blocks. What is a heart block? Look at it here. We'll come in an explanation. First degree AV block, second degree AV block, that's also called Mobich type 1 or Wenke back, or second degree type 1 and type 2. Type 2 is Mobich type 2 and or Mobich type 1 is also called Venki back easily. And this is what I was referring to the relationship by person just for remembrance of people. And third degree complete heart block. So how do you see? Look at the P wave differences of each one and dropping of the QRS and how distantly the difference between the 2:1 block, and you look at the third degree, the difference of general escape. This will be explained clearly. It is time to practice. So, what is it? Okay, again we'll come back. It's very now. Look at here. There is a QRS complex and PR interval is being extremely same as this one. Look at the distance of this PR interval and PR interval, but it's more than this. Okay, which is not supposed to be normal. What is PR interval normal? 0.12. So it's been there lengthened. And look at the second degree. Look at the PR interval. This to this, there is increase. This to this, there is increase. And again, there is a drop of QRS. That means this is a Wenckebach's phenomena, second degree heart block. And look at here. Look at the PR interval. Look at the PR interval same. PR interval same, but again, there is no QRS complex. So it's dropped. So again, it's easy way to look at it. That's called Mobich type 2. And look at the 2:1 block. So what happens is there's a every alternate QRS, there is a second degree wave block, there's a fall in the QRS. There's no electrical activity going to the ventricle and there's no electrical activity. P wave is there, but P wave is there, there's no QRS. Every alternate, it's called 2:1 block. What is the third degree? The complete heart block, which you requires at the earliest pacemaker, and this requires mechanical compared to the pharmacological goes with that. And what is important? Your requirement of the vitals is more crucial. And look at the third degree wave block. PR intervals are very much irregular, and there is no regularity between the QRSs are almost same. Look at the QRSs here: 1, 2, 3, 4, 5, 6, 7, 8, and again you look at here 1, 2, 3, 4, 5, 6, 7, 8. So this is what is on P waves has been irregularly continuous. That's called very long and lengthy. That's third degree heart block. Now, can you identify? Sir, can we go for this now? Rhythm identification. In the rhythm identification,
Quickly go because we have to identify. If we click on a question, it is going to be difficult now.
yeah.
You
So please look at it.
explain.
Okay. Can we just, are they going to answer this and go for the next clip, or shall I just go explain, sir?
Explain. No, don't explain much. Dear students, just identify the rhythm. We are going to have this exercise practically also, but practically what we need to do is when you see a rhythm, if it is life-threatening or not, what management it requires, you need to take a decision and decide the strategy within 15-20 seconds. So quickly, he will run the slides and you identify the rhythms. And you can write down in the chat box so that we can quickly finish up.
Yeah. Just only 3 minutes.
Yeah.
1001, 1002, 1003. Just for memory. Now, this is the rhythm. So, this is what is the rhythm of this? Look at it. Rhythm identification. What is the rate it's showing? 214 beats per minute, which is actually regular. Normally, which is going to be the ventricular rate is regular, and atrial rate unable to determine, and PR interval unable to determine. QRS duration 0.14. The QR, the difference is more than 0.12. So identification, what it is? It's been written here as monomorphic ventricular tachycardia. So the morphism, the monomorphism, because almost singular same way, it's monomorphic ventricular tachycardia. Please look at this. What is this rhythm identification? What is rhythm? So this is again, look at it. The ventricular rate is again 214 beats per minute, 271 beats per minute, whereas atrial, like you look at it, it's irregular. You look at the atria here, irregular, and The atrial rhythm is unable to determine both PR interval, unable to determine QRS duration. Here it's 0. More than 0.12. You look at this and this. This is up to 0.16 to 0.06. Look at it here. Here it's reduced. Here it is 0.12 to 1. It's very wide. Identification, monomorphic VT to atrial fibrillation. Normally, when you look at the patients and give the shock, they can convert into the monomorphic VT to the atrial fibrillation. It can be done. Sometimes it comes because you're treated. What is this? Please, again, those 5 things. Please understand. Rate, rhythm, P, QRS, distance, PR interval. That's all you have to see. For everything, the same pattern, no change. The rate, ventricular rate, 88, atrial rate, unable to determine, PR interval, unable to determine, QRS, 0.06. So there's no, it's okay. Identification, atrial flutter with ST segment depression. As we told, the ST is to be measured at a J point in the first diagram which we showed, or J60 point, which we can discuss later. The importance of it will tell you. This rhythm strip is from 52 years old man, found unresponsive, apneic and pulseless. Do you have any POV here? Again, look at the rate. Ventricular 88, atrial none, PR interval none because not seen. QRS 0.12 to 0.14 here to here because you saw that red calipers we have been measured there and shown in the slide, almost 14th slide. So it is accelerated idioventricular rhythm. We told you the rate is more than 100. So it is only the rate. Otherwise, same as Bizarre and same as size has been increased and no P wave here. Okay. This is a man of 78 years old complaining of shortness of breath. He has a history of COPD and CAD with hypertension. Also, he was hypertensive. So, what is it? As we said, simultaneously 2 leads to be read, we told you in the 44th slide, I believe. So, what is it? Lead to, right? Look at it, MCL. So, it is again ventricular rate 54 to 94, 55 to 94, and atrial rate unable to determine. PR interval 0. Unable to determine. There's no PR interval here. The P wave can be seen, not seen. And the QRS duration is 0.1 second. Please remember 0.06 to 0.1. So that means the QRS is okay with the size. But again, look at the distance of this one and look at this is the difference. There's no seesaw. Atrial flutter is seesaw, sawtooth. Atrial fibrillation up to 250 to 400, which has again controlled because there's a regular continuously having it can go to that level. There's no P wave seen properly, but at the same time, the fibrillation. Okay. Again, another 20 slides, taking time, we need to go faster. So it is 86 years old woman complaining of chest pain that she rates 4 on a scale of 0 to 100. Blood pressure is 140 to 72. So again, 60 breaths per minute. And please look at here, when you're looking at, look at the she rates, because chest pain that she rates 4 on a scale of 10, that's a visual analog scale when you call it as no. So what is it? Blood pressure is 140 to 72. So there's no issue of blood pressure. So 60 breaths per minute. Atrial rate 60 because every QRS before is P is there. Here. And the PR interval is 0.2 seconds. the maximum, and the QRS is 0.06 seconds, and it is a sinus rhythm. Because it doesn't mean that because the old woman we show this, because same thing 1, 2, 3, 4, 5, the steps. Rather 52 years old man, I don't think we call it as 52 years old, 52 years young people, young man with a substernal chest pain. He has a history of COPD and a mitral valve regurgitation, and BP is 140 systolic by 78 diastolic. Please look at it. Look at the P wave, QRS, and regularity between the RR interval. Look at the P intervals and the PR distances. And now look at it, what is happening here. 75 per minute, because 1, 2, 3, 4. 4 by 3, 300 by 4. Okay. Then again here, look at regular. Okay. PR interval 0.14 second and QRS 0.6 to 0.8. Everything else. What is issue here? Sinus rhythm with ST segment depression. Whenever, please understand few points here. Whenever there is a ST segment depression, if there is upward directly going with the concavity, if you see the concavity, that means it's not ischemia. If there's no concavity, then it is a risk of ischemia. Everywhere look at this concavity. So it depends on it may not be, because again we send for the 2D, send for this is different issue. But whether it has a 4 levels of how the ST depression comes, whether it's going to be convex, whether it's going to be having the straight upward or downward slope, all these things is because of ischemia. Please remember that. I think already this is easy for you. Asystole. Okay, easiest thing. Please understand, whenever we have this one, suddenly look for EC's leads placement correctly or there or not there, or amplitude is fully there or not there. This rhythm strip is 1 month old infant. We are talking about adult CCLS, but here it's been given here, so we have to explain. After a 3 minute seizure activity, which requires 100% increase of oxygen, we all know that 100 times. So what is it? Look at all QRS and P and PR interval, rate, rhythm, PR interval and size and QRS. Look at it. Every size. Do you have any difference here? It's a sinus tachycardia. Because actually, I do not know exactly 1 month old seizure. It's a sinus, but at the same time, the normal rate itself is more. So it's okay, because this is more than 130. We call it as a tachycardia and sinus. The rhythm strip of 77 years old woman with a congested cough. Please look at it. T waves. Again, 107 to 200 depends on the size between this. When you calculate totally, then we know the rate differences. Because if you take the first tool of this one, take 6 seconds and multiply with 10, that becomes easy. Or from here to here you take, it may be wrong. From here to here take, it may be very high tachy. That's the reason they have mentioned here is 107, here it's almost 200. It's irregular. And unable to determine atrial rate and PR interval, unable to determine. And the QRS duration, look at the QRS duration for all together, 0.6 to 0.08 here. So it's again, look at different, there's no difference of the size of this one of QRS, but there is an atrial rhythm is unable to determine and PR interval unable to determine. So atrial fibrillation. The rhythm strip from 54-year-old man who had a syncopal episode or TIA when he had. What is it again? It has a ventricular rate 58 beats per minute regular. Look at 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So that means the RR intervals are regular here. Atrial, again, look at the P. So regular. And PR interval, it's a consistent 0.2 seconds. Okay. And QRS, again consistent, 0.08 seconds. So identification, sinus bradycardia. This rhythm strip is from 43 years old woman complaining of palpitations. What is a palpitation? Which is a palpable or feeling of the heartbeat by yourself, and you have it's literally not only for thin individuals, but literally for self perception which he feels or she feels. How do you see? Look at the rate of ventricle and rate of atrial. Not able to determine because the P waves. And PR interval. Only when you see the P wave, then only will be able to see the PR interval. When you are not seeing the P wave, you cannot see. The QRS is almost same, 0.08 seconds, 0.8 seconds. So it is a supraventricular tachycardia. Supraventricular tachycardia has to be understood not only just by looking at the Valsalva, you have to look at the patient is a hypertensive or not hypertensive. Accordingly, we should treat. That will be discussing on electrical therapy. Now, look at it. When you have easy way of looking at it, please look at it here. The easy, again, same 5-step method. Ventricular rate, unable to determine. Atrial rate, unable to determine. PR interval, unable to determine. QRS duration, unable to determine. Ventricular fibrillation, the coarse ventricular fibrillation, because the QRS is bigger and wider, then we can say tachycardia. And look at the site, it's not regular. And again, it's a fibrillation. It's more than 350 to 400 per minute. This rhythm strip of 6 years old boy immediately after a seizure. So, as you said, it requires more than 100 times requirement of oxygen, but the look at the rate, it is not looking that tachycardia. But after the seizure, why he got this? Look at it. So, which is ventricular rate is 68 to 88. Again, depends on the size. It's not RR interval is not equal. And atrial also, every QRS is having. Do you have a PRA here? Please, every QRS is being followed or not? So the rate is the same, but at the same time, PR interval, because you can see here, you can see here, you can see here, you can see here, it's 0.12 second. And QRS duration is 0.08 seconds. So this is sinus arrhythmia. The change is there. It's arrhythmia, absence of rhythm. The same time, every P is followed before QRS and the size is been not changed. Okay. These rhythm strips are 44-year-old girl complaining of chest pain. Chest pain. Please understand, whenever you have a chest pain, this is easy. First also we showed. Can you see the QRS, there's no P wave and regular. What it is? Monomorphic ventricular tachycardia. Because I think we already explained, time is getting late. So we'll finish it off. Dr. Devan sir, you won't have questions or issues. Our time has been exhausted. Can we close it? Continue with the next.
To be one more lecture tomorrow on the brady and tachyarrhythmias, as well as on practical session also. So we don't entertain questions right now because it's already been very late. We'll straightway go to you. Stop sharing your presentation first.
Sure.
And the important thing is, for identifying any rhythm, these 5 points are very important. Students, please understand, this scheme of assessment of an ECG is what is the heart rate, how is the rhythm, how is the P wave, there are a couple of questions, what is PR interval, and how is the QRS complex. So only this answering these 5 questions in 10 seconds, you can identify the arrhythmia and you can come to the conclusion and decide your strategy, how you want to manage. So now we go to the next lecture.
Hope I have not taken much time. Sorry if it has been crossed my time. Thank you.
Divya,
Yes, sir.
Wonderful job.
No, this is a most exhaustive lecture. In fact, I must give a tremendous energy the way in which you gave the whole lecture.
As long as it's been conveyed, if I did justice, I'm thankful.
It's good.
Very true. I understand. It's a lengthy lecture. Can you reduce the size a little bit, Divya?
Is it okay, sir?
Go to minus or little more. Because you people use, you are not using Adobe PDF version. So where you can use like a PowerPoint. So you have to scroll your slides.
Yes, sir. Is it okay, sir?
Yeah, it's fine now.
Fine.
Students, very small 2 lectures left out.
So, good evening, everyone. I'm Dr. Divya. I'm the in charge of Department of Emergency Medicine at Geetham Institute of Medical Sciences. So, I absolutely thank Chakrarao sir and Rashish sir for giving me this opportunity. So, quickly, I'll go into the lecture without wasting any further time. So, transcutaneous spacing. I would like to open the chapter with a statement that it isn't as complicated as it sounds like. So once we hear about transcutaneous spacing, we are always like panicked because we are not used to it first thing, and then we haven't done much of transcutaneous spacing in our regular practice. So we have that discomfort in addressing it or thinking about it when we really have to. But this is one of the basic skills that every CCLS provider is ought to have. So let's just quickly go into transcutaneous spacing, and I'll simplify it as much as possible. For any doubts, you can drop in the chat box so that I can clarify later, so that we'll save some time, right? So what is transcutaneous spacing? The name itself tells you that it's something that you, through the cutaneous route, you're trying to pace. What is it like? Your pacemaker, your SNA, right? So it's basically nothing but your electrical stimulus that causes your electric depolarization of your cardiac muscle, causing contraction, and then giving an impulse that results in your heart rate and then cardiac output, and the cycle goes on, right? Yeah. So it delivers to the cutaneous electrodes like we already know. And then the indications, I think we're all very good at the theory part. I assume that all of you have reviewed your CCLS manuals well. Let's just quickly go into the indication. Unstable bradyarrhythmias. You know what is unstable bradyarrhythmia? CHAPS, right? Your altered mental status, hypotension, signs of shock, chest pain, heart failure, right? And then symptomatic sinus bradycardia. Again, if the patient comes with any symptoms and there's sinus bradycardia, you can think about transcutaneous spacing. And then 3rd degree heart block or Mobitz type 2 heart block, or any heart block that isn't responded to your drug therapy, and then you have a significant amount of period of time for you to shift the patient to any either transvenous or permanent pacemaker or whatever, till you correct the cause that's causing the brady. That is when you can think about your transcutaneous pacemaking, right? Like I said, it's a bridging method, temporary bridging method between your temporary pacemaker or your permanent pacemaker. And you can also consider this in sick sinus syndrome or bradycardia with symptomatic ventricular premature contractions, if only it's symptomatic. If it's not symptomatic, do not think about this. Contraindications, we are all aware of it. Hypothermia. So I just quickly want someone to type in the chat box why hypothermia is an absolute contraindication. And then it's not recommended for asystole. One, for the reason it doesn't have any evidence that it is effective in asystole. And the second one, if only there's a defect in the conduction, you can try giving an impulse so that you can generate an output. But if there's no impulse at all in your cardiac muscle, it's totally dead. What's the point of giving an impulse? It wouldn't trigger anything, right? So it doesn't have any role in asystole. And then coming to prosthetic tricuspid valves and right ventricular infarcts, it's not absolute contraindication, but relative contraindication is you have to be watchful about it, because when there's a prosthetic valve or a right ventricular infarct, you would require a lot of electricity or a lot of output to generate an impulse. If the more amount of electricity you give, the more damage to the myocardium. So the more damage to the myocardium, the more chances of ischemic heart failure. So it's related that way. So if it's absolutely indicated in a patient with right ventricular infarct or prosthetic tricuspid valve, you can consider, but you have to be absolutely watchful with ischemic heart failure, right? And with the hypothermia, let me clarify. I haven't seen anything on the chat box. I don't know why. So with the hypothermia, in hypothermia, bradycardia is a physiological response because of the decreased metabolic heart rate. That's one. And then the second one, even if you think it's symptomatic, it's an absolute contraindication, because in hypothermia, your myocardium is more sensitive to fibrillation and more resistant to defibrillation. So giving an electrical impulse, the chances of fibrillation are high, and then your chances of defibrillation will be reduced. So don't think of TCP when there's hypothermia. And then, yes, coming to precautions, it's just like the precautions you take for your defibrillation. Like there's a possibility of skin damage, pain, discomfort, considering pain and discomfort because the patient is conscious oriented, like obviously. So you will be thinking about the pain and discomfort that the patient can have, and the skin damage, obviously. And then the electrical hazards, presence of water because of the conduction, right? And then oxygen, any flammable substances, any metal contact or whatever. And then make sure you are not placing the electrodes on the ECG electrodes. And then make sure all your wirings of the electrodes are well, and there's no any break of your wirings and all, or it's not damaged. Like, and then one important thing that you have to think when you're putting a patient on transcutaneous pacing is do not check your carotid pulse, right? If you check your carotid pulse, because of the muscle twitching, the twitching can itself mimic a carotid pulse. So you would assume that this carotid pulse. So if the patient is unresponsive, try to pause the pacing, assess the rhythm immediately, and proceed accordingly. But do not go with the carotid pulse if the patient is unresponsive, because that could not be a pulse, that just could be a muscular twitching. And then these are the few common terminology that one should be aware of before thinking of TCP. The basic ones, with no rocket science, just the basic ones. One is capture. Capture is nothing but when your ventricles are capturing and giving you an impulse, giving you an electrical stimulus. Your impulse is taken and then the stimulus is given. That's your capture, to simplify. And then capture can be visualized with on the monitor. You can see just before the QRS, you'll have a spike. I'll show you in the, on the upcoming slides. You do have that. You can see that, right? And then the output is the electrical stimulus that is required to trigger a depolarization is the output, right? And then the output threshold is the minimum amount of electricity that can generate an impulse for a patient is the threshold. Always make sure that you give a minimum of 2 milliamps or 10% more than the output threshold. That should be your output. Your output threshold is different. That's where your stimulus, actually you get a stimulus. Above that is your output. And then no output is something, is a caution that you have to see that there's no output that's been delivering to the heart. Your transcutaneous pacing is not working, right? Yeah. And then contraindications, which is absolutely important. It's okay if you know when not to, when to do, but it's absolutely important that you know when not to do, because that would complicate the patient more, right? So when they're intermittent or mild symptoms and the patient is tolerating bradycardia well, these are the situations when the transcutaneous pacing could complicate the patient's condition rather than the existing condition. That's one. And then if the patient is, this includes symptomatic heart block also, but with stable escape rhythms, which is of no harm, that the patient will land immediately, right? And then, like we already discussed, prosthetic tricuspid valve or right ventricular infarct, we already discussed risk of acute ischemic failure because of it requires much higher milliamps to generate an impulse in these patients. Yeah. Equipment, we all are aware that we need a defibrillator with pacing function. Just the defibrillator wouldn't pace. Make sure that your machine has the pacing function. Know your machine first, right? And then you must have adult pads and crash cart or an emergency trolley. IV access is mandatory to the patient. I'm sure that is something that all the patients have, because we directly don't go for transcutaneous pacing in most of the situations. We try the drug therapy and then go to the transcutaneous pacing. So I assume that we all have an IV access, and then make sure that we all have masks and the resuscitation bag and the suction equipment. This is all for the backup if the patient crashes, right? And then since it is done on patients who are relatively conscious, make sure that you provide patient comfort. It will be absolutely discomfort giving an electrical impulse every now and then in a minute. So make sure you sedate the patient and make sure you give proper analgesia, right? If the hemodynamics are not well, at least make sure you give mild sedation. And yeah, one important thing I would like to tell here is your defibrillator can either work as a defibrillator or a pacer. You can't use both the functions on the same machine at the same time. This is absolutely important. For you to connect the pacing option, you need to deconnect the defibrillating option. There's a wire that's your paddles. If you're aware with the machine, any machine that you have that with the pacing option, you have paddles attached to your defibrillator. You have to remove the connection, and there's one more attachment that comes with the paddles, with the electrodes. That is what you're supposed to connect. You can't use, if you have to defibrillate a patient, you need to remove the pacing option and then connect the defibrillator option, right? So you have to connect the electrodes. And then the pad placement is just like the pad placement for the defibrillator. You can use it either both sides or front and back. Front on the apex and the infracapsular review, or front and back. Yeah. This settings are the like I would say the buttons vary from machine to machine, but pretty much the concept is same. You first need to switch on your machine, make sure you put the machine in the pacing mode, make sure you've deconnected the defibrillator pads and connected your pacing pads, and then you have only two modes in pacing. One is demand mode and the other one is fixed mode. To simplify, demand mode is something that if the patient already has an impulse, that is enough, your machine won't give any impulse. If the patient doesn't have an impulse, that is when your demand mode acts. But the fixed mode, irrespective of the patient's impulse, it keeps giving the impulses at the rate that you have set. So always it's better to start with the demand modes to see if how the patient is tolerating, and then go for the fixed if the patient is not tolerating well or the impulses are not properly generated, right? So this is a pacing. If you can see, there's a pacing mode option that's there. And then this is the heart rate dial where you can set. Always make sure that you set the heart rate at the most lowest level possible. Start with 60 to 80. Especially in the ACS, do not go with the higher heart rates even if the hemodynamics are not stable, because that would only further progress the ischemia and worsen the patient's condition. So always have this in mind, 60 to 80, right? And then this is the output dial where you can adjust. You can start with 20 milliamps and you can go up to 120 to 140 milliamp, but that's a lot of electricity, I would say. But you can always start with the basic, and it depends on patient to patient. Like we already discussed about the terminology there, like the output threshold, no output. You think of that and then decide, right? And then you have, this is on the screen, you can see the set pacing heart rate that you have set and the output generated. So if there's 0 milliamps that you can see, you have to adjust, because there's no electricity that's being delivered to your heart. Yes. So if you can see here, there's a impulse can be seen as a straight line, just a spike just before the QRS. That tells you that that is coming not from your SA node, the impulse is coming from your pacemaker. That confirms that your output is adequate. Like in any other machines, troubleshooting is one important aspect that we all have to be aware of. First, make sure if your pacing is working or not, and then make sure if it's capturing or not. And always think about the cause. Always think about the cause, because this is only a temporary measure. This is not a permanent measure. Address the cause. This is only giving you time to address the cause and plan for a definitive management. Check the pads placement and check if there's adequate skin contact. With no skin contact, again the electricity is not delivered. Clean and shave if necessary, because you all know that hair again will not deliver adequate electricity that we intend to. Change the defibrillator pads. This is absolutely important. This is something that most of the people forget, like probably in the panic situation or whatever, right? And then ensure that rate setting is adequate. Do not go for too high rates. Start with 60 to 80 and make sure your battery is all set to go, right? Always check if the patient's bradycardia, if the impulse is not generated, and if you can see that it's not the pacing impulse that you can see on the screen, make sure you go with your troubleshooting and check everything and make sure it's all okay. Thank you.
Thank you. Well done.
Thank you, sir.
Very good, very nice presentation. You have explained it so well, and people are tired. I know you also must be tired, but you justified your time very well.
Thank you, sir.
There are many things which we want to discuss on this, but let us have finished the lecture first.
Yes, sir.
We have a next lecture, is intraosseous approach, probably. Dr. Murthy?
Yes, sir. I am ready.
Yeah.
Good evening, sir.
Divya, plus stop sharing your presentation.
Oh.
In fact, let me tell you, yesterday we discussed AED, today we discussed transcutaneous pacing, and next is intraosseous. Now, these three modalities of emergency medicine are very much underutilized in our country. which I recently, when I was in Germany, I told you yesterday also, every ambulance has the infrastructure having all these facilities. Every ambulance, I would say, had the facility for all these things.
Very true, sir. AED, transcutaneous spacing, and IO access are something like this. How much ever we familiarize with the lectures and all, it still is a foreign language for all of us.
Right. Very true.
Many places there are not even atrocious guns. Many hospitals.
Yes, sir.
And even many people who are trained or might have not seen the atrocious gun.
Correct. Now,
Share this one.
Yes, set the screen, but the presentation he has to search.
Yes, now it is there.
Sir, just click on the old tools across so that you will get better space on the right side.
Good.
That's
yeah, may all rightness. Okay.
thank you, sir.
Not Mary. The intraosseous cannulation is always a second choice. Whenever the IV cannulation is not possible, then only we have to think of the intraosseous cannulation in case of emergencies. This is access directly to the bone marrow cavity, and it is a alternative to the peripheral IV access for the drug as well as fluid administration, including IV resuscitation. This includes all the resuscitation guidelines, including the pediatric life support, trauma life support, or anything. And it can be used in all the ages, for right from, and it is very easy in infants and children, and it is very easy in old people also, because demineralized bones, it is very easy to cannulate. Whereas only young people, it is difficult. For emergency medicine, this is indications for any of the injections or fluid administration. Whenever the patient comes in shock, we are not able to get the IV line. No, even after the cut down, we are not able to cannulate. Then we have to think of the intraosseous line. It can be used for blood sampling or laboratory tests also. It can be used, and actually it is almost equal to the drug delivery system. Is almost equal to the intravenous. That is one the wonderful thing about the intraosseous line. And if we take especially in the femoral humerus, if you take in the upper end, just below the head of the humerus, if we take that, it will be very near to the heart, and it any drug that is given, it reaches heart very fast, and that is almost equal to the in any of the fluid administration also is very comfortable with intraosseous line whenever the IV line is not possible. And it is sometimes it is time taking also if it is mechanical, and if it is a drill is there, we can do it very fast. And IV line takes more time sometimes, but intraosseous line is very fast with if we have a drill, arrow drill. And intraosseous line is indicated only in the case whenever the IV access we are not able to get. Next thing is if the patient comes in shock, and if we are not able to get the life-saving emergencies like cardiac arrest, then we can take the intraosseous line. If the patient is very obese and we are not able to get any of the landmarks, we can select, we can think of the intraosseous line. And sometimes in the pre-hospital, in the ambulance also, we can take, because patient will be moving and IV line will be difficult, we can take intraosseous line in the ambulance also. And this is the manual. We can, with a drill, we can, with a drilling movement, we can press on with the thumb, we can introduce. Only precaution we have to take, we should not keep our hand below the area where we are pressing, because sometimes it slips and injures our hand. And it can be the proximal end of tibia, just 2 centimeters before the condyle of the tibia, and the lower end of femur also, it can be above the condyle, about 2 centimeters above the condyle. It can be, we can select. And the distal tibia also above the medial malleolus, about 2 centimeters above the medial malleolus, we can select. And sometimes it can be sternum. Sternum also, it is, of course, it is, well, because we may have to use some xylocaine if we have to, and it is periosteum is also very very painful, so we have to use xylocaine as a pain killing for before getting this interosseous line. Then iliac crest from anterior superior iliac spine to the posterior superior iliac spine, anywhere we can get the this thing. And this arrow is the 10 technique. This is the drill, by means of which we can directly drill the bone, and we can get the line, and later we can connect the 3-way with extension, and we can have the IV fluids or any drugs we can take, we can do sampling. And there are 3 sizes. This is the pediatric size, and this is adult size, and this is extra large size. We can use it for the humerus, upper end of humerus cannulation. We use this. Next, these are the areas I told you at the proximal tibia, about 2 centimeters below the tibial tuberosity, and distal tibia is about the malleolus, and distal femur also it can be introduced. And there are some complications, and actually in the IV line there is because the muscles will contract, there will not be any leak. It will keep the approximate the area, but here there is nothing, like bone is all open, and there is leakage is possible. And sometimes we may be introducing some infections and extravasation of the drugs and fluids, whatever we give. And sometimes if there is hematoma and all, there can be subcutaneous abscess can be there. And sometimes it's the removal of the needle can break in the bone, and it means removal may be difficult sometimes. And contraindications for this interosseous line, whenever that is there is a fracture in that particular bone, we are not supposed to introduce interosseous line. And the previous surgery in that area also, we are not supposed to select that area for interosseous line. If there is infection in that, the skin infection or bone infection or burns, we should not select that area for the interosseous line taking. And if the patient is already having osteomyelitis of that, we should not select that area. And if that this interosseous line has been tried about 24 hours back or within 1 day, that is there is some difficulty must have been there. That's why better to select the other area. Inability to locate the landmarks is another difficulty in getting interosseous line. And thanks a lot. We got the opportunity of taking the interosseous lines in our house surgency period itself, in our pediatric treatment rooms, where the patients were totally gastroenteritis patients coming with pulseless, babies coming pulseless. And we used to give interosseous line and 200 ml of fluid. Then we used to get, it used to be comfortable later to take the IV line. That initially we used to give interosseous IV fluids through the interosseous line. Sir, I am finishing my talk. Yeah,
Thank you, sir. Okay, sir. Just stop sharing your presentation.
thank you.
In spite of,
How to,
please stop sharing your presentation.
how to,
And above you will find stop share.
okay, sir. Now,
Then stop sharing again. Stop sharing.
stop sharing.
Top. On the top, you will find stop sharing.
Stop sharing. Okay. Okay, sir. Thank you.
Okay. Now everybody can open their.
Doubts.
I must tell that we started 15 minutes late. ECG lecture was the longest and one very exhaustive. Hats off to Dr. Mohan Maharaj. He has taken a lot of pains to talk on ECG. I understand it is a very difficult lecture to talk, and people, if you are not attentive, they get they do not get the message also properly. And still, we are only 6 minutes late. So we are very much in time today also. Yesterday it was not 10:30, but today 6 minutes we are overpassed not because of the speakers, but we started 15 minutes late. So to all the students, I request that tomorrow, please try to be 10 minutes earlier. Tomorrow's session is little shorter, but I want to have a lot of discussion on all the subjects. Probably we'll miss out certain things when we'll meet for the practical session on 6th October. So any question is there? People writing in the chat box, or people have started leaving probably. The important message was that when we talk about comprehensive care, 3 things we learn, which we have failed to learn in our undergraduate curriculum. Yesterday the AED, and today the intraosseous approach, which is not we have never put into practice. As Murthy sir said, I was teaching this in 1999 to 2000 in trauma courses only for pediatric injuries. But since 2005, it has come in ACLS also, and even for any age, for adults, and at multiple places. So you rightly said that once it was used only for pediatric patient. And we also didn't have the gun, but we were using the bone marrow biopsy needle or bone marrow aspiration needle, which is something which should have an IV set connector on the backside and should have a stellate. And in those days, in 2000, 2001, you know, the thicker 20 or 18 gauge lumbar puncture needles were available. And that also served the purpose because we didn't have the guns those days. Nowadays, these guns are easily available and each needle costs around 5,000 rupees, but that we can afford in such cardiac.
When the gun is costing 2.5 lakhs.
No, sir.
Teleflex is the marketing.
40,000. Sir, it is available in 40,000.
Maybe another brand, but this Teleflex is marketing.
It's a Teleflex.
There are some videos also with the Teleflex.
And second is Survey Company in probably Noida or somewhere. They are manufacturing. I hope Lukman can get one tibia and the gun for demonstration on that day.
I think.
I have one here with the big tibia model also, and from which is costing around 40,000 or something. But the tibia model costs 40,000 more. So the set is 50,000. And then another important lecture was the transcutaneous pacemaker. Let me tell you, if you look at the AED on various airports or somewhere, there are a couple of things we need to have in the box. One is there should be a scissor to cut the clothes of the patient. There should be some tissues to wipe out the sweat, because when he got an infarct, usually he is very wet. So, or sometimes he has been brought from the swimming pool or in the rains. So there should be some tissues to wipe out and a razor, disposable razor to clip the hair, because otherwise the AED is not effective. So these 3 things are always there along with the AED in the box. And we see that we should have it also when we order an AED in our place, a couple of things. And Second is this capturing will teach you on practical sessions how to do the electrical capture and how to do the mechanical capture, which pulse you check when you do the mechanical capture. Those things will teach you on the skill sessions. And also there will be a lot of rhythms analysis will tell you, because the scheme of 5 points which Mohan Maharaj explained number of times in his lecture, you must understand the easiest way to identify the life-threatening rhythm. Normally, sometimes only 3 things. In 10 seconds, you see what is the rate, how is the rhythm, how is the QRS complex, and it gives the diagnosis in emergency situation. So that things you need to develop the reflex when you see the rhythm. I think we will end the day today.
Take the opinion of some people, sir. Jaya Lalwani, will you say something?
So it was lovely, though exhaustive sessions. Looking forward for conduction at Raipur, the hybrid ones.
Yeah, Dr. Jaya will be there someday.
Yes.
We'll
I
fix
believe
up-
we can teach better than face to face. Face to face is also good, but what we actually wanted to do is we wanted to conduct a small examination with after every lecture. Then only the hybrid will be more successful. Otherwise, some people, if we conduct hybrid, some people they keep the computer on, go somewhere and come back. It is not the thing. What our main idea is completely they should learn and practice. Otherwise, it is not for the certificate purpose of certificate. It is not for the purpose of saying teaching something and doing the work. It should be useful, practical, and it should be a lifesaver. That is all. What about others? Anybody wanted to say something? Comment on
I
the.
think tired and I'm a resident doctor, PG students, because they must be doing the whole day duty and they're joining at night.
Yes,
Some
sir,
may,
true.
maybe even vanishing for the night duty even right now. So, anyway, but we'll patch up the things which we think we have missed out in the online class on the day of the demonstration and questions.
Rashesh, this is Venugopal. Nori.
Tell me.
Sir, this is yesterday I asked you one question. How to get these special circumstances in the IRCS website?
With certificate?
No, not certificate. It is special circumstances information or videos in the IRCS website. You're not able to get it.
It is not there. It is not there. We'll
Okay,
keep
sir.
it.
Okay, sir. Okay, thank you.
We have to create, sir.
You have to create.
We have to.
The PowerPoint.
Okay, so call it a day. Good night,
Okay,
everyone.
sir.
Sleep well.
Okay, sir. Tomorrow.
Thank you,
there
sir.
are
Thank you very much.
Many people
Good
have
night,
asked
sir.
you-
Thank you, Chakarao Garu.
Thank you very much, sir.
Good
Thank
night,
you,
sir.
Divya.
Thank you,
Good
sir.
night, sir.
Good
Good night,
night.
everyone. See you tomorrow
Good
at
night, sir.
8.
Thank you,
Yes, sir.
Rashesh.
Yes, sir.
Thank you, Chakra, sir.
Okay.
Thank you, sir. Good night, sir.
Thank you. There was a record, I think it is recorded on the YouTube.